Welcome back to the deep dive. Today we are opening a file that I think a lot of us think we have a handle on, but if you haven't looked at the literature in, say, the last 3 to 5 years, your mental model is likely obsolete. We are talking about pulmonary hypertension.
hmm
And specifically, we're looking at this through the lens of the clinician. We aren't just reviewing the basics. We are really dissecting the paradigm shift that has happened in this field.
It really is a paradigm shift. I think for a long time, pulmonary hypertension was viewed almost as a static hemodynamic state. You have high pressure, you give a vasodilator, simple plumbing.
Right.
But what we're seeing now, and what is detailed so meticulously in our source material today, is that this is a dynamic, biologically complex, and honestly, a systemic malignancy of the vasculature. It is far, far more than just a pressure number.
So we are going straight to the gold standard here.
No question.
And I want to start right out of the gate with a statistic from the text that I found, frankly, disturbing.
I have a feeling I know which one you're going to cite. It's got to be the diagnostic gap.
It is. The text highlights that despite all our advances in imaging, despite the ubiquity of echocardiography, and, despite increased awareness campaigns, the average delay in diagnosis for pulmonary arterial hypertension, or PAH, remains up to 2 years.
2 years.
2 years from the onset of symptoms to the time a physician actually labels the disease and starts therapy.
It is a sobering statistic. And for the doctors listening to this, I want you to pause and just think about what 2 years actually means in the context of this specific pathology. We aren't just talking about a patient feeling tired for 2 years.
No.
We are talking about 2 years of unchecked progressive vascular remodeling.
That's the key. It's not a dormant period.
Not at all. I mean, during those 24 months, the pulmonary vascular resistance is climbing. The right ventricle is undergoing hypertrophy, then it starts to dilate, and eventually it uncouples from the pulmonary artery. By the time that diagnosis is finally made, we are often dealing with a right ventricle that has sustained a really irreversible insult. We are starting the race 10 steps behind.
So our mission statement for this deep dive is pretty simple. To close that gap, we want to equip the clinicians listening with the nuance needed to catch this earlier. And I think the best place to start that process is by redefining what we're actually looking for. Because if you trained even a decade ago, the numbers in your head, the actual hemodynamic definition of the disease, are probably wrong.
They likely are. For a very long time, the dogma was absolute. Pulmonary hypertension was defined as a mean pulmonary artery pressure, or MPAP, of greater than or equal to 25 millimeters of mercury. That was the cutoff.
Just a binary number.
Totally binary. 25 was disease. 24 was normal.
But Harrison's makes it clear that bar has been lowered.
It has. The new definition, which is supported by the World Symposium and reflected in the 22nd edition, is a mean PAP-P of greater than 20 millimeters of mercury.
So we've dropped the threshold by 5 millimHg. Now, I can hear the skeptics, or maybe just the overworked hospitalist, asking, is this just academic grade inflation? Are we just trying to label more people with a disease?
Right. Is this just disease mongering?
Yeah, exactly. Or is there a genuine clinical imperative behind shifting this goalpost?
That is a fair question. But the answer is definitively clinical. This wasn't a decision made in a vacuum. It was driven by data showing that patients sitting in that specific gap, patients with a mean pressure of 21, 22, 23 milliMHg, they were not normal.
Okay.
When you followed these patients longitudinally, they had worse outcomes. They had higher mortality and higher hospitalization rates compared to people with truly normal pressures, like, below 15.
So we were essentially ignoring clinical stage A of the disease.
Precisely. We were waiting for the pathology to become florid before we even acknowledged it. By lowering the threshold to greater than 20 milliMHg, the goal is to identify these patients when the vascular remodeling is, hopefully, more modifiable.
Right.
We want to intervene before the concrete sets, so to speak.
But it's not just the pressure, is it? The definition of precapillary pH, which is the group we are most worried about, the true vascular disease, also involves the resistance.
Correct. And this is so important. Pressure is a variable number. It depends on flow. You can have high pressure just because you have high cardiac output, like in anemia or hyperthyroidism. That's not vascular disease.
It's just more flow through the same pipes.
Exactly. To call it pulmonary arterial hypertension, we need to see increased resistance in the pipes. And the threshold for pulmonary vascular resistance, or PVR, has also been lowered. It used to be greater than or equal to 3 Wood units.
And now?
It is now greater than 2 Wood units.
That's a significant tightening of the criteria.
It is. A PVR greater than 2 Wood units, combined with a mean P-PAC greater than 20 and a normal wedge pressure. That is the new hemodynamic footprint of early PAH. And recognizing this earlier footprint is the only way we are going to chip away at that 2-year mortality gap.
Okay, so we've established that we need to look closer and earlier, but what are we actually looking at? I want to move into the pathobiology section because for a long time, I think the prevailing mental model for most non-specialists was simply vasoconstriction.
The pipes are squeezed.
Yeah, the pipes are squeezed, so we give a vasodilator to relax them. But Harrison's described something much more sinister.
It is much more complex than just a spastic pipe. I mean, if we're just vasoconstriction, calcium channel blockers would work for everyone. But they don't. They work for a tiny, tiny fraction.
A very small fraction.
Yeah. What we are dealing with, and what the text emphasizes, is a fundamental molecular hijacking of the vessel wall. In fact, the source material draws a direct comparison to the biology of cancer.
Cancer-like. That is a very strong analogy for a cardiovascular disease. Let's unpack that. What are the shared traits between a pulmonary artery in PAH and, say, a tumor?
It really comes down to cellular behavior. In a healthy vessel, the cells lining the wall, the endothelial cells and the smooth muscle cells, they have a life cycle. They grow, they serve their function, and when they're old or damaged, they undergo apoptosis.
Programmed cell death.
Right, they die in a programmed, orderly fashion. They politely exit the stage.
Okay.
But in PAH, these cells develop what's called apoptosis resistance. They acquire mutations or epigenetic changes that allow them to just ignore the best signals. They refuse to die.
So they stick around.
They stick around, and at the same time, they exhibit unchecked proliferation. They start dividing rapidly. So you get this accumulation of cells, endothelial cells, smooth muscle cells, fibroblasts, just piling up in the vessel wall.
So the wall gets thicker and thicker, encroaching on the lumen from the inside.
Correct. It obliterates the lumen. But there's another layer to this cancer analogy that I find just fascinating, and it's metabolic. The text discusses metabolic dysregulation, specifically something called the Warburg effect.
I remember the Warburg effect from biochemistry, but almost exclusively in the context of solid tumors. You know, glioblastomas, pancreatic cancer. Why is it happening in a blood vessel?
It's the exact same survival mechanism. Normally, a cell with access to oxygen, and remember these are lung vessels, they're literally bathed in oxygen, will use mitochondrial oxidative phosphorylation to make energy.
It's efficient.
Super efficient. It produces a lot of ATP, the clean energy of the cell.
Right.
But in PAH, the pulmonary artery smooth muscle cells, the PASMCs, they flip a switch. They just stop using the mitochondria. Instead, they revert to aerobic glycolysis. They start churning out lactic acid, even in the presence of abundant oxygen.
But that's incredibly inefficient for energy production. I mean, why would a cell choose a bad energy plan?
Because it's not about energy, it's about biomass. Glycolysis provides the carbon skeletons, the metabolic building blocks, needed to synthesize lipids, nucleotides, and amino acids rapidly.
So it's about building materials for new cells.
Exactly. The cell is sacrificing energy efficiency to fuel its rapid division. It is gearing up for war, essentially. It is prioritizing growth over function.
That is such a critical insight. It explains why simply dilating the vessel isn't enough. You have a cell population that is metabolically reprogrammed to act like a tumor.
That's it. And the result of this cellular anarchy is the histological hallmark of the disease, the plexiform lesion. If you look at a slide, it looks like a chaotic, disorganized tangle of capillary-like channels. It's an aneurysm-like dilation just filled with proliferating endothelial cells.
So it's a dead end, functionally.
It's essentially a vascular dead end. Blood goes in, but it doesn't really go out.
And it's not just the cells themselves, right? The environment around them, the extracellular matrix, the ECM, that changes too.
Yes, the scaffold changes. You get this massive expansion of the ECM, but it's not normal tissue. It's fibrosis. You get deposition of non-fibrillar collagens and fibronectin. This makes the vessel wall incredibly stiff.
Okay.
So the right ventricle is trying to pump blood through a system that is not only narrowed by the cell growth, but also rigid due to the fibrosis. It's a double hit to compliance.
Which explains why reverse remodeling is such a holy grail. You can't just relax a scar. You have to fundamentally degrade it.
Precisely. You have to break it down.
So we have this molecular storm.
Yeah.
What kicks it off? We have to talk about genetics. The source material puts a massive spotlight on one gene in particular, BMPR2.
Bone morphogenetic protein receptor type 2. If you are a clinician, memorize that acronym. BMPR2 is the most common hereditary cause of TAH. It accounts for, about 70 to 80% of heritable cases and even a significant chunk of sporadic ones.
But it's not a simple one gene, one disease situation, is it? I mean, the penetrance is famously low.
No, and that's the tricky part. The penetrance is low, arguably as low as 20%. That means you can carry a pathogenic BMPR2 mutation and live your entire life without ever developing pulmonary hypertension.
So it needs a second hit.
It implies that the gene loads the gun, but something else, a second hit, maybe inflammation, a virus, a drug, pulls the trigger.
I want to dive into the mechanism of BMPR2 because understanding this is the key to understanding the new therapies we'll discuss later. Harrison describes a balance, a signaling seesaw.
It's the perfect visualization. Imagine a seesaw controlling vascular health. On one side, you have the anti-proliferative forces. This is the BMPR2 pathway.
Okay.
It signals through intracellular proteins called SMAD1, SMAD5, and SMAD8. Think of these as the brakes. Their job is to tell the vascular cells, stay calm, don't divide, undergo apoptosis when you're supposed to.
Okay, so BMPR2, which signals through SMAD1, 5, and 8, is the brake.
Right. On the other side of the seesaw, you have the pro-proliferative forces. This is the TGF-beta and activin pathway. They signal through SMAD2 and SMAD3. Think of these as the gas pedal.
Right. They drive growth.
They drive growth, fibrosis, and survival. So in a healthy person, the gas and the brake are perfectly balanced.
But in PAH?
In PAH, because BMPR2 is downregulated or mutated, the brake line is cut. You lose that SMAD158 signaling. The seesaw tips violently toward the activin TGF-beta side.
So it's all gas, no brakes.
All gas, no brakes.
Ooh.
And that unchecked gas leads to the proliferation and the cancer-like changes we just discussed.
And that's exactly what the newest drugs are targeting.
Correct. And this is why the new drug sotatercept is so revolutionary. It targets this specific imbalance. But we'll save the therapeutics for the end. It's too exciting to give away now.
Okay, deal. Before we leave genetics, there's one other gene I want to flag because it carries a specific clinical warning label, EIF2AK4.
Yes. This is the gene associated with pulmonary vein-occlusive disease, or PVOD, and this is a critical distinction to make.
Why? I mean, what's the difference?
In classic PAH, the obstruction is in the small arteries, the arterioles. In PVOD, the obstruction is in the venules and small veins. It's postcapillary.
Okay, so downstream, why does that distinction matter so much for the doctor at the bedside?
Because if you treat a PVOD patient with standard PAH vasodilators, you can cause a catastrophe. Think about the plumbing. If the drain, which is the veins, is blocked, and you open the faucet wide, you dilate the arteries to let more blood in, what happens?
The pressure rises in the middle and the capillaries, and fluid just leaks out.
Flash pulmonary edema. You can precipitate acute respiratory failure. That is why identifying the EIF2AK4 mutation or seeing the signs of PVOD on a CT scan-like septal thickening or centrolobular ground glass opacities is absolutely vital.
So what do you do with those patients?
These patients need urgent referral for transplant evaluation, not standard vasodilators.
That is a life-saving pearl. Okay, we've covered the molecular hijacking, but one thing the 22nd edition emphasizes heavily is that pulmonary hypertension is not just a disease of the chest, it is a systemic disease.
We have to stop looking at the lungs in isolation. We just have to. The systemic effects are profound, and they explain a lot of the patient's suffering. The right ventricle is the first domino, obviously. As it fails, we get venous congestion.
And that congestion just backs up everywhere. Let's trace it. The kidneys.
The kidneys take a massive hit. It's a classic cardiorenal syndrome. You have high central venous pressure, the CVP, transmitting back to the renal veins, causing congestion.
So they're swollen.
They're swollen and congested, and at the same time, the cardiac output is low, so renal perfusion is down. It's a double whammy. Congestive nephropathy plus prerenal azotemia.
And the liver, same story.
Same story. Congestive hepatopathy, we sometimes call it cardiac cirrhosis. You can see a pulsed liver on exam, elevated enzymes, and eventually fibrosis, all from the back pressure.
But the one that really stood out to me in this chapter, and one I think is often overlooked or just written off, is the effect on skeletal muscle. Sarcopenia.
This is fascinating physiology. We used to look at these patients and they're frail, they're thin, they're weak, and we'd assume it was just deconditioning.
Right. It seems like a logical assumption.
It's a very logical assumption.
Yeah.
We thought, well, they can't breathe, so they don't move, so their muscles atrophy.
But it's not that simple.
It's logical, but it's incomplete.
Mhm.
The research now shows that there is an intrinsic molecular switch happening in their muscle fibers, driven by the disease itself.
What kind of switch?
Skeletal muscles are made of type I fibers, which are slow twitch. For endurance, they're oxidative, and type 2 fibers, which are fast-twitch, glycolytic, and very fatigable.
And in PAH.
There is a fiber type switch.
Yeah.
They lose their type I endurance fibers and they switch to the type 2 fatigable fibers. So even if they try to exercise, their own physiology is fighting them. They become easily fatigued because their muscles are literally changing composition to a less efficient type.
And that's driven by neurohumoral signaling, right? The systemic inflammation and sympathetic overdrive from the disease.
Exactly. It creates a state of volitional muscle atrophy. So when a patient tells you, "Doctor, my legs feel like lead," or "I just have no strength," believe them. It's not just laziness or lack of gym time. Their muscles are failing them at a cellular level.
That's a huge point. Okay, let's pivot to the clinic. We have this complex systemic disease. How do we find it? The papers highlight that the most common symptoms are dyspnea, shortness of breath, and fatigue.
And that's the problem.
That describes half the people in any waiting room.
Exactly. "Doctor, I'm tired and I get winded on the stairs." They could be COPD, heart failure, anemia, or you just haven't been to the gym in 5 years.
The notes mention this specific danger called diagnostic anchoring. I found this fascinating.
It's a cognitive bias. A doctor sees a patient with, say, mild lung disease, sees the shortness of breath, and thinks.
Case closed. It's just the lung disease acting up.
And they miss that a whole separate entity, pulmonary hypertension, has developed on top of it. The clue they miss is proportionality. The breathlessness is way out of proportion to the original disease.
Okay, but by the time it's obvious, we're in trouble. The text describes the signs of right ventricular failure edema, that jugular venous distension.
That's late-stage stuff.
But the symptom that really stopped me was syncope, fainting.
That is the ultimate red flag.
Why is fainting such a specific marker? I mean, I usually associate it with something simple.
It's pure hydraulics.
Yeah.
In PH, the vessels in the lungs are clamped down. The right heart is trying to pump blood through these narrow pipes. Now, you exert yourself, run for a bus.
Your muscles need more blood.
They're screaming for it. But the right heart can't push harder through that resistance. So cardiac output actually drops right when it needs to rise, blood flow to the brain cuts out, and you drop.
It's a catastrophic supply and demand failure.
Precisely. And if a patient who supposedly has asthma is fainting on exertion, that is not asthma.
So let's say we aren't waiting for them to faint. I'm the clinician. Patient just feels off. What am I looking for? The sources get really specific about auditory clues.
You have to listen to the second heart sound, S2,
Yeah.
the dub in lub-dub. That sound is two valves closing. The aortic and pulmonary, usually they're soft, but if the pressure in the pulmonary artery is sky high,
It slams shut.
it slams shut. We call it an accentuated P2. It's a loud, sharp sound right at the top left of the sternum. That's high pressure.
Like the difference between closing a door and slamming it in a draft?
That's a perfect way to visualize it. You might also hear a murmur from the tricuspid valve leaking. That's the sound of the heart literally stretching and failing under the strain.
And there are clues on the outside of the body, too. I was surprised to see autoimmune signs listed so prominently.
Oh, yeah. Autoimmune conditions are a huge, often overlooked driver. The text mentions sclerodactyly.
The tight, shiny skin on the fingers.
Exactly. And telangiectasia, those little red dilated blood vessels. If you see those hands and the patient has shortness of breath, you have to be thinking about scleroderma-associated PH. It's a very specific phenotype.
Okay, so we have our suspicion. Now we go to the toolkit. ECG, X-ray, echo. Well, hit the ECG first. We're looking for right ventricular strain.
Right. The ECG is an electrical map of muscle mass. Normally, the left ventricle is the big boss, so the signals are all left-sided.
Yeah.
But in PH, the right ventricle has to bulk up to fight that pressure. It gets huge.
So the electrical balance shifts.
It completely shifts. You look at lead V1, which is right over the right heart, and you start seeing these tall, peaked R waves. The text also mentions ST depression. That's the electrical signature of the muscle screaming that it's under strain.
Then the chest X-ray. The terminology here was very visual, specifically pruning.
It's a stark image. The main pulmonary arteries in the center of the chest are huge, but as you look out toward the edges of the lungs, the blood vessels just disappear. They're clamped down. It looks like a tree with a massive trunk, but no branches.
And that other term, the obliteration of the retrosternal space.
Sounds like a sci-fi movie, doesn't it?
It really does.
On a side view, there's usually a dark, empty airspace behind your breastbone. If the right ventricle gets massive, it physically pushes forward and fills that space. It obliterates it.
Okay, now to the MVP of screening, the echocardiogram. This is where we get our first real number.
This is the most important initial test. We're using ultrasound.
Mm.
We look to see if the right ventricle is dilated or if the septum, the wall between the ventricles, is being flattened. The main number everyone looks for is the PASP, pulmonary artery systolic pressure. We want to know if it's over 35.
The notes also mention a bubble study. What's that? They inject agitated saline.
It's literally just salt water shaken up to create microbubbles. They inject it into a vein. Normally, those bubbles go to the right heart, into the lungs, and get filtered out. You shouldn't see them on the left side of the heart.
So if you do see bubbles on the left side...
It means there's a hole, a shunt.
Yeah.
The bubbles bypass the lung filter. And finding a shunt is crucial. It completely changes the treatment plan.
But here is the catch, and it feels like a big one. The source material has this massive warning box about the echo.
This is the trap.
It says a normal echo report might not rule out pH. It all comes down to the tricuspid regurgitation, the TR.
It's a physics problem. To estimate the pressure, the machine measures the speed of blood leaking backward through the tricuspid valve. It uses the Doppler effect, like a radar gun.
And then it uses math to turn speed into pressure.
Right. But here's the problem. A radar gun needs a car to bounce the signal off of. The echo needs a jet of leaking blood to measure.
So if the valve is working perfectly and it's not leaking...
There's no jet. And if there's no jet, the machine can't calculate the pressure. The report might come back saying normal pulmonary pressures, but what it really means is unable to calculate.
That is terrifying. The stat here says in 1/3 of patients without detectable TR, pH might still be present.
Absolutely. So if you have a symptomatic patient and the echo says no TR detected, you cannot just send them home. You've just hit a technical limitation.
Okay, so moving from screening to function, the walk and the breath. The 6-minute walk test seems pretty low-tech.
It is low-tech, but it's high value for prognosis. It quantifies the misery. But for diagnostics, we look at CPAC cardiopulmonary exercise testing.
The mask on the treadmill.
Yep. It helps us differentiate. Is the limitation cardiac, pulmonary, or just deconditioning? A peak oxygen consumption under 15 is a bad sign.
I want to pause on the athlete anomaly from the sources. This challenges how we think about normal ranges.
This is the hidden patient concept.
Yeah.
Imagine an elite marathon runner. Their baseline VO2 max might be, say, 70.
A Ferrari.
A total Ferrari. Now they get early stage PH. Their function drops by 40%. They're now at a VO2 max of, what, 35, 40?
But if a doctor looks at a chart of average values...
A 35 is perfectly average. It looks normal. The doctor says, you're fine, just getting older. But for that patient, they have lost nearly half their capacity. They're telling you something is wrong.
So the comparison shouldn't be against the population. It has to be against the patient's own history.
Always. If an active person hits a physiological wall, that is pathology, even if their numbers look average.
Now, the source material mentions this concept of an individualized strategy. It explicitly warns against just robotically following a flow chart.
If I have a patient who's a 30-year smoker, I'm thinking about lung function.
Of course.
But if they have a history of cardiomyopathy, my first thought is immediately heart failure.
Exactly. And you have to start with those non-invasive clues, the things that hint at what's really going on inside.
Which brings us to pulmonary function testing. There's a very specific red flag the data points to, which is that isolated reduction in DLCO.
Right, the diffusing capacity. It basically means the mechanics of breathing, moving air might look totally fine.
But the oxygen isn't getting across into the blood.
Precisely.
Yeah.
And if you see that drop without some major airway obstruction, that is a massive clue for pulmonary arterial hypertension, PAH.
And while we're on clues, the imaging, the high-res CT scans, they give you that peripheral pruning visual.
Yeah, it's such a vivid term. You look at the scan and the main arteries are swollen, but the small outer branches, they just sort of disappear.
They're pruned away. But here's a rule from the guidelines that I found, well, kind of surprising. Everyone gets a sleep study.
Everyone. It seems like overkill, but it is absolutely non-negotiable.
Even if they don't snore or have other symptoms.
Even then, losing oxygen while you sleep, nocturnal desaturation, is incredibly common in PH. It's like a stress test that happens every single night. If you miss that, you're missing a huge piece of the puzzle.
Okay, so we've gathered clues. Now we have to rule out the imposters. And the big one seems to be CTEP.
Chronic thromboembolic pulmonary hypertension. This is the one we absolutely cannot miss.
Because it's from old blood clots.
Yeah.
Right. And it's potentially curable.
It's the only form that's potentially curable with surgery. The tragedy is how often it's missed.
We also have to mention something showing up more in the blood work. methamphetamine use.
It's becoming a major driver of PAH. So when you screen for HIV, for liver disease, autoimmune markers, you have to ask about drug use now.
And before going invasive, we check the BNP levels, the heart's stress gauge.
Exactly. If the right heart is struggling, BNP goes up. It helps grade severity, and it gives us a baseline to see if our treatments are working later on.
All right, we've done the perimeter checks. Now we have to go inside. The gold standard. Right heart catheterization. You cannot diagnose PH on an echo alone. You have to go in. We thread a catheter into the right side of the heart and directly measure the pressures.
And we're looking for a mean pulmonary arterial pressure MPAT greater than 20.
That's the definition. But getting that number is only half the battle.
This is where we need to classify the patient into one of the hemodynamic buckets, and distinguishing these buckets is the critical clinical skill.
It is. We have three main hemodynamic profiles. First, precapillary pH. This is your classic group 1 PAH. The problem is in the lungs.
What are the numbers for that?
The numbers are MPAP greater than 20, POWP, or wedge pressure, less than or equal to 15, and PVR greater than 2. The wedge pressure being normal tells us the left heart is fine.
Okay, so that's bucket 1. What's bucket 2?
Isolated postcapillary pH. This is group 2, left heart disease. The numbers here are MPAP greater than 20, but the POWP is high, greater than 15, and the PVR is normal, less than or equal to 2.
So the problem is the left heart.
Correct. The pressure is high, but the wedge is high. The lungs are just a passive victim of the backup. The resistance in the pipes themselves is normal.
Misdiagnosing the plumbing type can kill the patient.
It's critical. You have to treat the root cause. If you have postcapillary pH, your lake is already overflowing, and I give you a vasodilator to open the dam's floodgates. What happens?
You flood the lake.
You flood the lake. You cause flash pulmonary edema. The patient effectively drowns.
Wow.
If it's the left heart, you treat heart failure. If it's the lung arteries, then you use the specific pH vasodilators. You cannot mix them up.
And the third bucket, the one that causes the most confusion.
Combined pre- and post-capillary pH, CPC-PH. This is a patient who has left heart disease, so their POWP is high, greater than 15. There's back pressure. But the chronic congestion has triggered that cancer-like remodeling in the pulmonary vessels, so the PVR is also elevated, greater than 2.
So you have two problems at once.
You effectively have two diseases, a failing left heart and a remodeled pulmonary vasculature. These are incredibly complex patients to manage.
And while we're in the cath lab, we have to talk about vasoreactivity testing. Who gets it and why?
Okay, so we perform this primarily for patients with idiopathic, heritable, or drug-induced PAH, so specific subsets of group 1. We expose them to a short-acting vasodilator, usually inhaled nitric oxide, during the catheterization.
And we are looking for responders, but the definition of a responder is really strict.
Very strict. To be a responder, your mean PP must drop by at least 10 mmHg, and your cardiac output must remain stable or increase. All three must be met.
Why do we care so much? What's the payoff?
Because the treatment is radically different. If and only if they are a true responder, we treat them with high-dose calcium channel blockers, CCBs. It's a simple oral therapy, diltiazem or amlodipine, and they can do very well for years.
Now let's tour the groups. Let's start with Group 1 PAH. This is the true vessel disease, right?
Correct. This is where the arteries themselves are remodeling. They get thick, they get fibrous, the actual tube gets tiny.
Okay, so if you asked a doctor in, say, 1987 to describe a PAH patient, who would they describe?
Oh, they'd describe a young woman, maybe 30, 36 years old. That was the classic textbook idiopathic PAH patient.
But looking at the new registries in our deep dive, that profile has completely changed.
It has. If you walk into a PH clinic today, the average patient is somewhere between 54 and 68 years old.
That's a huge gap. Are we just missing it in young people now, or is the disease actually changing?
It's probably a mix of things. We're definitely better at looking for it in older folks. 20 years ago, a 65-year-old is short of breath. We'd say, you're getting older. Now we screen. But it also shows that this vascular remodeling isn't just a young person's thing.
But the gender divide is still there.
Oh, yeah. It's still about 3 times more common in women. But there's this really interesting and kind of grim nuance in the data about men.
This stood out to me. Men get it less often, but they do worse.
Significantly worse. Men tend to show up with much more severe hemodynamics at the time of diagnosis.
Why is that? Are they just waiting longer to see a doctor?
That's the million-dollar question. It could be delayed presentation, a tough-it-out mentality. But there might also be some biological differences in how their right ventricle adapts to stress. Either way, if you see a man with PAH, you have to be aggressive. He's likely starting from a much worse place.
Now, group 1 isn't just random bad luck. There are specific subtypes. The genetics really caught my eye, that BMPR2 mutation.
Heritable PAH. Yeah, this is usually the worst case scenario for group 1. If you have this mutation, you tend to get diagnosed younger and the disease is just more aggressive.
Another big one in group 1 is connective tissue disease, specifically scleroderma.
This is a huge category, systemic sclerosis. But you have to be really careful here because scleroderma is tricky. It can push you into a group 1 or a group 3.
It depends on the type of scleroderma.
Right. If it's limited cutaneous, mostly skin stuff, they tend to get the vessel disease, which is group 1. But if it's diffuse scleroderma, they get scarring of the actual lung tissue, interstitial lung disease.
Right.
That pushes them into group 3.
And I'm guessing the treatment for group 1 versus group 3 is completely different.
Night and day. So even within one disease, you have to stratify.
Okay, let's talk about the hidden causes of group 1, because this is where the global perspective really hits you. In the US, we think genetics, maybe some drugs, but globally, it's worms.
This schistosomiasis.
The stats are just staggering. 230 million people infected worldwide, and 5% of them get PAH.
Which, by pure numbers, makes it one of the most common causes of PAH on the planet.
How does a parasite cause high blood pressure in the lungs? It feels like such a biological disconnect.
It's a triple threat. First, the worm eggs can literally get stuck in the pulmonary vessels, so that's a mechanical obstruction. Second, the body hates these eggs, so it launches this massive inflammatory attack, which remodels the vessels.
And the third?
The worms damage the liver. That causes portal hypertension, which we know can trigger lung issues all on its own.
So if you have a patient who emigrated from an endemic area, parts of Africa, Brazil, Asia, and they're short of breath,
you have to check for eggs, urine, stool samples. If you don't think of it, you will absolutely never find it.
Another cause on the list is HIV.
HIV-PAH. A very tough diagnosis. Prognosis is generally poor.
Yeah.
But there's a fact here that trips up a lot of clinicians.
The viral load. Right.
Right. There is no correlation between how much virus is in your blood and whether you get PH. You could have perfectly controlled HIV, an undetectable viral load, great CD4 count, and still develop this severe vascular remodeling.
So you can't look at a healthy HIV patient and just assume their lungs are safe?
Absolutely not. The mechanism seems to be an inflammatory cascade that gets started early and just persists, even when the virus is suppressed.
Let's move on to the liver. Pulmonary hypertension. This section felt like a trap for surgeons.
It is the transplant trap.
Yeah.
This happens in patients with liver failure. The high pressure in the portal vein somehow triggers the lungs to clamp down hard.
And the problem comes when they need a new liver.
Exactly. A liver transplant is a massive hemodynamic event. You're unclamping major vessels, flooding the system with volume. If you do that to a patient whose lungs are clamped tight, specifically if their PVR is over 3.0 Wood units, their heart just can't handle the shock.
It fails right there on the table.
Or shortly after. The mortality risk is huge. That's why a PVR over 3.0 is basically a do not transplant sign, or at least a treat the lungs first sign. Even a PVR above 2.0 is now a yellow flag. You absolutely have to check the lung plumbing before you give someone a liver.
I want to touch on one last specific case from the notes: congenital heart disease, Eisenmenger syndrome. This felt like a heartbreaking race against time.
It really is. If a child is born with a hole in the heart, a shunt, blood flows from the high-pressure left side to the low-pressure right side. It just floods the lungs.
And over years, the lungs react.
They harden. They thicken to protect themselves. Eventually, the resistance in the lungs gets so high that it exceeds the systemic pressure. The flow actually reverses.
And once it reverses,
you've reached a point of no return. If the PVR gets too high, you can no longer surgically close the hole. If you did, the right heart would be pushing against a brick wall with no escape valve. It would fail immediately.
So you have to catch it before the vessels remodel for good.
You have to. Once Eisenmenger sets in, that window for repair is closed.
Okay, we've spent a lot of time on group 1, the pure vessel disease. But we need to talk about its big neighbors, groups 2 and 3.
Which are actually the most common types you'll see in practice.
Group 2 is that left heart disease we talked about, the backup.
Heart failure with preserved ejection fraction, valvular disease. The key here is you fix the heart to fix the lungs. You treat the root cause.
And group 3 is lung disease, COPD, emphysema, pulmonary fibrosis, the hypoxia group.
The mechanism here is interesting. It's the body trying to be smart. If a part of your lung is damaged and not getting oxygen, Your body constricts the blood vessels going to that area. It shunts the blood to the good parts of the lung.
That makes sense. Don't send blood where there's no oxygen to pick up.
Exactly. But in a disease like COPD, the bad area is, well, everywhere. So the whole system constricts.
But there was a warning in the guidelines about the severity of the pressure in Group 3.
This is a crucial clinical pearl. Usually in Group 3, the pH is mild to moderate. The mean pressure might be 25, maybe 30. But if you see a COPD patient with a pressure of 45 or 50, alarm bells should be ringing.
Because COPD alone shouldn't cause that high a pressure.
Right. It suggests pH out of proportion to lung disease. It means there might be a second hit. Maybe they have Group 1 disease on top of their COPD, and those patients have very poor outcomes.
Now we have to talk about Group 4. Of all the groups, this one felt the most dramatic, CTEPH.
Chronic thromboembolic pulmonary hypertension. This is the do not miss diagnosis. If you remember one thing from today, remember CTEPH.
The definition is simple enough. Old blood clots that scarred over. But the statistic that just stopped me cold was the patient history.
You're talking about the silent PE stat.
25% of these patients have no history of a clinical pulmonary embolism. They never had the chest pain, the collapse, the ER visit, nothing.
That is the nightmare scenario. They had silent clots. Maybe they felt a little winded one day, maybe a calf cramp. They ignored it. The body didn't dissolve the clot. It just turned it into scar tissue.
So they show up years later with heart failure and have no idea why.
And the doctor might not suspect clots because there's no history of them in the chart.
Why is this the do not miss group? What's the urgency?
Because unlike every other group we've talked about, where we manage the disease Group 4 is potentially curable.
We don't use that word very often in PH.
Almost never. But with CTEPH, if the clots are accessible, a surgeon can go in and perform a pulmonary endarterectomy. They put the patient on bypass, cool the body down, and they literally go in and scrape the fibrous scar tissue out of the arteries.
That sounds incredibly invasive.
It is, but the result? Patients can wake up with near normal pressures. They get their lives back. And if you miss the diagnosis, and you treat them with pills instead of sending them to surgery, you have denied them a cure.
And the sources were very clear. A normal CT scan or an echo is not enough to rule this out.
No. A standard CT can easily miss the thin webs of scar tissue. The gold standard screening tool is the VQ scan ventilation perfusion. If you have unexplained pH, you must order a VQ scan. It's non-negotiable.
Thank you for guiding us through all the plumbing today. It's a dense topic, but a really vital one.
My pleasure.
And to all of you listening, breathe easy, keep asking questions, and we'll see you on the next deep dive.